So Dr. Tripura will be speaking on phacoemulsification in hypermature cataract.
Yeah. Good morning, everyone. On the onside, I want to thank IPOS and AIOS for giving me this opportunity. Today, I'm here to talk about the phacoemulsification in hypermature cataract. I'm working as a consultant at CFS Vijayawada. Hypermature cataracts, as we all know, are challenging at numerous steps of phacoemulsification surgery. These can be broadly classified into Morgagnian type and a sclerotic type. Morgagnian type is nothing but the cortex undergoes autoliquefaction and turns uniformly milky white, and the nucleus loses its support and settles to the bottom. The sclerotic type is the same, but it has calcific deposits over the lens capsule, and sometimes it may present along with iridodonosis and phacodonosis. Coming to the surgical steps, for a beginner, it's always better to give a peribulbar block to start up the surgery and to give a pre-operative mannitol. Once you give the peribulbar block, it's mandatory you soften the eyeball by using a pinky and giving a digital massage. The incision, it's better you give a limbal incision rather than giving a clear corneal incision. To start with, you can do only a side port or a partially opened main port so that the AC doesn't collapse as such. Trypan blue staining is a must in cases of hypermature cataract as it doesn't have any red glow and it helps us for better visualization. As such, the surgery is as easy as that except for the capsular rhexis. Capsular rhexis is the major part of the surgery. So for doing a good capsular rhexis, viscoelastics play a very important role. Tri-soft shell technique can be used in which we inject viscose dispersive OVD, which is nothing but a viscoat, injected around 25% on the anterior capsule and then followed by an Helon 5 which is injected underneath. So anterior chamber should always be formed. So there are many types of capsular rhexis which have been described by many other many procedures. The most commonly used is the two-stage capsular rhexis. Coming to the needle decompression, in this we put just a 25 gauge or a 26 gauge needle into the anterior chamber through the main incision, and then we just puncture the anterior capsule and remove the liquefied cortex in around 0.1 to 0.2 ml at one go. This is nothing but a two-stage rhexis which is popularly used, and it is first described by Gimbel in 1993. In this, the initiation of the rhexis is always better to do with an cystotome, and it should be a C-shaped flap so that it doesn't cause an Argentinian flag sign, and then followed by the completion of the mini rhexis with the help of the rhexis forceps, micro rhexis forceps or the Atrata forceps, whichever you are comfortable with. And then we have to aspirate the fluid with an IA cannula or a Simcoe cannula or with a hydro cannula of your choice. And then once the mini rhexis is over, it is as usual as the same rhexis in which we can give a small nick with a micro rhexis scissor or a Navanas, and then we can just extend the rhexis to the required adequate size of around 5 to 6 mm, which is very helpful for doing the phaco. In this, usually 90 to 95% of the cases will achieve the capsular rhexis. Once the capsular rhexis is achieved in hypermature cataract, it is as similar as any other surgery which we do in our day-to-day practice. This is nothing but a flax, which is femtolaser assisted cataract surgery. This gives promising results, but the only constraint here is because it has an liquefied cortex, sometimes it may interfere in the subsequent laser pulses, and then it may cause gaps. So it's better once you enter into the anterior chamber, you just see to that with the forceps that the total capsule is freed with the laser pulses. Next is phacocapsulotomy. It is described by Mohan Rajan sir. It is nothing but the phaco probe is injected into the anterior chamber. It is put over the anterior capsule, will give the ultrasound energy, will puncture the capsule and also remove the liquefied cortex at one go. Some surgeons also do an NDAG capsulotomy in which we'll do an laser shot in the OPD and then go ahead with the surgery at the OR. So coming to the nucleus management, once the capsular rhexis is over, the nucleus management is as same as the previous speakers have spoken about the hard cataracts. But here I want to just tell you 2-3 points because it's an empty bag. It doesn't have an posterior capsular support. It's always better we have to think about the PC. So it's better you'll do a vertical chop. The vertical chop, after doing a vertical chop, you can do it in a burst mode because it causes less of damage to the corneal endothelium. Here I have done a small trench in which, and then I have buried totally the phaco tip and then started separating it. It's better you rotate it totally 180 degrees, make it into 2 halves, and then go and make it into 3 pieces, that is at least 8 pieces, and then remove each piece by piece so that the endothelium will not be damaged. When coming to the last piece, it's better you go to the sculpt mode because it doesn't have much of vacuum and it doesn't cause much of surge, and the risk of PCR also get reduced. And once the nucleus, once the nucleus has been, once you embed the dip, it's better you have to see that the posterior pole has been totally separated, in which we have to occlude the probe totally, see to it the posterior plate is totally separated, and it becomes as piece by piece. And once the pieces have been done, the posterior plate should be captured and then start from behind. Once the surgery, once the capsular, once the nucleus has been taken care, the IOL of your choice has been, can be placed in hypermature cataracts. Coming to the surgical complications, the most dreaded complication is an Argentinian flag sign, which we all face once in a way. Maybe it is less than 1%, but still it is really a nightmare for us. There is one case where we got, so we have gone ahead and just extended the rexus with the rexus forceps, and then we have circularized the rexus, and then because being a soft cataract, we have done the new phacoemulsification and implanted an IOL in the sulcus. We have to place a 3-piece IOL in front of the back. However, the haptic should be placed 90 degrees to the direction of the anterior capsular tear. So posterior capsular rupture, it's always difficult to place an IOL in posterior capsular ruptures, but still when you have a fragment, nuclear fragment remaining, when you get a posterior capsular rupture, it's better you use an IOL scaffold technique, in which you'll put a 3-piece IOL inside the AC, and then you make the nucleus piece sit over the IOL, so that the IOL acts as an tamponade, and the PCR will not extend any further. So here we put the phaco probe and then emulsify the nucleus. Depending upon the support of the anterior capsule, you can go ahead and put it in the sulcus, or you can go ahead and put it in a scleral fixating or a glued IOLs as such. So take home points, liberal use of viscoelastic is a major step for any hard cataracts for that case, but in this case capsular is much more important. For that, the liberal use of viscoelastic is a must. Informed GVP consent for the attender and the patient, and the risk of not putting an IOL and taking up for a secondary IOL should also be explained to the patient and the attender as well. Capsular rexus is the major part. Once the capsular rexus is achieved, it is as easy as a cakewalk, which can be done by any of us. Intact posterior capsule and preserving the corneal endothelium without any damage is utmost important, and you should have a backup of iris claw lenses and also a 3-piece IOL in your armamentarium. Don't hesitate to ask for a help if you really have a retina consultant, if you get a PCR or a zonular dialysis. Convert if needed. Thank you so much for your patient listening.
Nice presentation. As far as the femto is concerned, you know that there are adjustments for the capsulotomy. You know that?
Sir?
In a femtorexis, you can modulate the energy parameters for the things.
Yes.
For this, what I put is supra fast. What is the duration of the rexis in the normal rexis?
But in case of femto, sir?
In case of femto. Duration of the laser.
I don't have much of idea, sir, because I
Yeah, normal duration is 1 second. Whereas special supra fast, it is 40% of that, 40% of that, where for the intumescent cataracts, we put that. The only thing is it is fast and the vertical height is more than the normal. So it definitely makes a cut even in the intumescent cataracts. But as you said, stain. After that, stain, whether it is separated or not, if at all not separated, it is easy to separate because already postal stamps are there.
Yes, sir.
So it is much comfortable with femto in these cases. The other thing is, you made a small rexis, again scissor, again large rexis. For that, what I give is, make a small rexis, don't detach that flap. Keep that flap at the end. So with that flap, you make a spiral.
Yes, spiral rexus.
Easy. Rather than again introducing the scissor, the moment you introduce the scissor, that itself may run away sometimes.
Yes.
If you are vertical. If you are tangential, it is okay.
Yes.
So that also time taking and more skill than leaving a spiral. You do the spiral, whatever you want, and be on the lesser side, complete your course. After implanting, again you do the rexis.
Yes, sir. Yes.
Nice presentation.
Thank you so much.
One or 2 points I want to make is that the rexis is a problem, especially in Morgagnian cataracts. So one has to be well versed with the rexis by forceps than by needle rexis. So the problem with the forceps is that you press the incision posteriorly and there is a leakage of the
Viscoelastic.
visco. and that leads to shallow EC, and that can lead to the runoff of the rexus. So the beginner should be then well versed with the use of forceps in such situations.
Yes.
Number second is that once you are having an Argentinian flag sign, for the beginners it's better to convert it to the SICS.
True.
Number second, if you want to continue with the phaco, then you have to pull the nucleus out of the bag and do a supracapsular phaco.
So wonderful presentation, Dr. Tripura.
Thank you, sir.
I have one very basic question, and my basic question is, to begin with, you did the hypermature cataract surgery because the intraocular pressure was normal. But in the beginning slide, you said you want to give mannitol. Now, if we want to understand the physics of the hypermature cataract, it's the intralenticular pressure which is high. It's not the intraocular pressure.
Ocular pressure. Yes, sir.
Now, how does mannitol help in reducing the intralenticular pressure?
As
If it is associated with glaucoma, you are right.
yes.
If the
There is
intraocular pressure is normal, there is no role of mannitol.
Usually we'll not give any mannitol preoperatively, sir. Usually we'll just give an topical anti-glaucoma medication before, just a drop of Dorzox before I take to the surgery OR. But in case when we have an borderline IOP of around 23 or 24, then I prefer giving a preoperative mannitol half an hour before we take up for the surgery and then go ahead with the surgery. It is just that it reduces the overall intraocular pressure, so that it doesn't help us in any the lenticular pressure as such, but still overall the surgery becomes easier with ease. Sometimes we end up with a floppy iris in these cases, which we really don't know. For all those, it may help. That's what that is.
But
and
basic physics of
Is
the
there is no role.
intralenticular pressure.
there is no role of intralenticular pressure is not reduced with any mannitol. Sir.
Mannitol. So another important thing is, don't depend on simple methyl cellulose. Keep ready the Helon for this rexis.
Yes.
Inject Helon and start the rexis.
Thank you very much.